Good morning. I'm Peter Stanton, publisher of the Worcester Business Journal. It's my pleasure to welcome you to our annual Central Mass Healthcare Forum. This annual gathering of industry leaders delivers insights about the future of the healthcare sector in our region. And I expect this morning's conversation will live up to that high standard based on our keynote speaker and all-star panel that we have with us this morning. Making this annual forum happen each year takes a lot of planning, and we appreciate the support we have had for years from our event partner and presenting sponsor, Fallon Health. The Fallon team has not only supported the event, but been a valued think tank partner when it comes to picking timely topics and finding expert speakers. At this time, I'd like to give Fallon Health's president and CEO, Richard Burke, the opportunity to share some welcome remarks. So Richard, the floor is yours.
Thank you, Peter. It's great to be with you and with all of those attending this session today. My understanding is we have very strong attendance, and I think that's a testament to the great work that the Worcester Business Journal does in bringing keynote speakers and great panelists to our community on very timely topics. Today's topic is one of those, healthcare reform, where we are on this journey in Massachusetts and as a nation. And we couldn't have a better keynote speaker than Dr. John McDonough, as well as panelists who you'll hear about in a few minutes. Fallon Health, as Peter says, has been a proud partner with the Worcester Business Journal for many, many years. We are a 45-year-old company. We are both a provider of health insurance and a provider of health care. We provide coverage largely for Medicaid and Medicare enrollees across Massachusetts and into New York. And so the topic today is one that's of vital interest to us as a local employer in the healthcare space, and one that provides coverage across the Commonwealth and as I said, into New York. So we are so proud to be a partner with the Worcester Business Journal. Look forward to continuing our partnership with Peter and his team. And we appreciate the opportunity to be with you today. So I'll turn it back over to Peter. Thank you.
Thanks, Richard. Appreciate it. And it's now my pleasure to introduce our keynote speaker. But before I do that, just a few notes for those attending the session. If you want to submit a question for the panel, you can do that in the Q&A box, which is located at the bottom or the top of your screen, depending on your device. And we'll get to as many of those questions as possible during the panel discussion. The session is being recorded, and the link of that recording will be shared with all attendees after today's session. And after we hear from our keynote speaker, we're going to have a moderated panel discussion. And I'll be splitting that with Brad Kane, WVJ's editor. So now it's my pleasure to introduce Dr. John McDonough. John is a professor of practice at the Harvard T.C. Chan School of Public Health in the Department of Health Policy and Management. Between 2008 and 2010, he served as a senior advisor on national healthcare reform to the U.S. Senate Committee on Health, Education, Labor, and Pensions, where he worked on writing and the passage of the Affordable Care Act. Between 2003 and 2008, he was executive director of HealthCare for All, Massachusetts consumer health advocacy organization, where he played a leading role in the passage of the 2006 Massachusetts Healthcare Reform Law. From 1998 through 2003, he was an associate professor at the Heller School at Brandeis University. And from 85 through 97, he's a member of the Massachusetts House of Representatives. Wow, a long career, including politics. And there he chaired the Joint Committee on Healthcare. Dr. McDonough holds a doctorate in public health from the University of Michigan and a master's in public administration from the Kennedy School of Government at Harvard. And I just want to add that if we were live, John just gave the panelists in a little pre-session a nice opening yoga exercise to keep us all kind of loose in our chairs. So I don't know if that's, you're going to start with that, John, but we appreciate that and look forward to hearing your remarks.
Thanks, Peter. I think I'll take a pass on the yoga right now. We'll plan that for next year. So thank you for welcoming. Thanks to the Worcester Business Journal and the Fallon Health Plan and all the participants and folks who've been involved in putting this together. It's a pleasure and an honor to be here. In particular, I get as much out of this as I give, I hope, because I know a fair amount about what's going on in the national level. I know a fair amount about what's going on in the Massachusetts healthcare system. And I'm always interested and excited to learn more about what's happening in Worcester. It's a very special community. It's got some terrific medical care providers. It's got the Fallon Health Plan as a major force. It's got some world-class community health centers and just an excellent system. And like every place else, it's a large city, a lot of challenges, and it's interesting to see how those play out. But so I'm going to share my screen. I've got about 20 minutes to do kind of an overview for you on a couple of important themes around what's going on in the US healthcare system right now that's particularly noteworthy and might be of interest to folks in the Worcester community and the Worcester business community, and also a little bit in Massachusetts. And then in the discussion, we can bore down into what's happening in Worcester. So just a few key points. The United States continues to demonstrate some significantly poor trends in healthcare outcomes and health status across many domains. In the past 2 years, there have been two major laws that have been passed: the American Rescue Plan, sometimes called ARPA, and the Inflation Reduction Act from this last summer, called the IRA, that are making some important and meaningful policy advances that I want to explain. And then I'd like to put Massachusetts a little bit in context in terms of its leadership on the health care cost control agenda, which is a significant, substantial role, even though the results are perhaps a little more mixed than we might otherwise prefer. So those are my 3 points. I will try to get through these slides as quickly as possible. Start with the bad news. So some of the bad news. So the United States continues to be the outstanding leader in the world in terms of how much we spend on medical care services. We spend more than twice the average of what's referred to as the OECD nations. OECD is the Organization for Economic Cooperation and Development, based on Paris. It's the legacy of the old German Marshall Fund, and they do incredibly valuable comparative analysis of leading national healthcare systems, including the United States. And so here you can see at over $12,000 in, this is the data from 2019, 20, and 21, we spend a lot. We spend a huge amount, and way more than any of our peers who, as we'll see, have health outcomes that are, for the most part, significantly better than ours. You know, there's nothing wrong with spending this amount of money if in return for it, we could brag that we have the best healthcare outcomes and system and quality in the world. And unfortunately, that's not what we have. Here's another way to look at the spending. This is over 40 years from 1980 to today. This is healthcare spending as a percent of gross domestic product. And you can see here the other leading countries that are part of this mix are 10 advanced countries who we refer to a lot in terms of our comparative purposes. And what's fascinating about this chart, of course, if you look at it, you go back to 1980, the US is, of course, the dark red line on top. We were probably one of the most expensive systems back in 1980, and we were very much in the pack of these 11 nations, of the 11 including us. But it was sometime in the early 1980s that for the first time around 1982, 83, that we broke loose from the pack, and the distance between us and other countries has just been going up and up and up. Notice that all countries are growing in terms of spending more of their national wealth on health, just none at all at the rate that we are spending. And again, nothing wrong with this if in return for this we had world-class outstanding results, which we don't. Here are some examples of that now. Oops, let me jump ahead. Here's probably the core measure of population health that we look at. There are others, infant mortality and so forth, but life expectancy is an important one. And here is life expectancy at birth. Again, I like to go back to 1980 to give some sense of distance. Here are a number of leading advanced nations. And here's the country average, the blue line, and here's the United States. So if you go back to 1980, we were an underperformer in life expectancy, going up and down. But again, in that decade, we started to create distance between us. So you notice our life expectancy, for the most part, with a few exceptions, like in the early 90s, has been going up. But in recent years, since about 2013, 14, it's been some slow declines. And then, of course, a steep drop here because of COVID. And that's going on across the world. But look at the slope of the downturn with the comparable countries versus the United States. And again, these are jaw-dropping. So in 4 of the past 7 years, the United States life expectancy has gone down. In these good old days here, we used to think that we were beyond that and that it was up and away. By the way, if just based upon money and how much we spend, our life expectancy should be somewhere up here, around 85, given the resources that we spend. So this is a troubling indicator. Here's another one that is a part of it when you unpack what's in the life expectancy. And one of the leading increases are deaths from alcohol, drugs, and suicide. And again, going back to the late 1990s, we can see that it's been going up, particularly going up on drug deaths, particularly over the course of the past decade. But when we look at it, and there's a book that came out a couple of years ago called Deaths of Despair, which catalogs this and analyzes this in a compelling way, by Deaton and Case from Princeton. So this is a part of the story, as certainly you all know, in Western Massachusetts. Here's another part, obesity and diabetes. Take a look at these 3 maps, these 2 sets of 3 maps. The top level is obesity on body mass index measure. And here's diabetes prevalence, and it's state by state. And you can see there's some difference among states, but the trend from 1994 to 2000 to 2015 is in one direction, and it's in the wrong direction on both obesity and, of course, its closely related counterpart, diabetes. Here's a different kind of a disturbing and growing problem, which is the prevalence of medical debt. People in the United States who are carrying large amounts of unpaid medical bills. And by the way, most of the people carrying this massive debt are people who have health insurance. They simply have insurance, which leaves them significantly exposed through cost sharing and deductibles in particular to massive medical care bills. Some of these surprise medical bills, lots of different pieces, but totaling the estimate of about just under $200 billion in medical debt all across the country. And of course, more than 2/3 of it from medical debt, more than $10,000. It's becoming much more of a national topic that's going to need to be addressed. We talk about student debt. This is another kind of debt that is quite serious. Why do we spend so much? The general consensus among experts across the country, right, left, and center, basically the evidence shows that the reason the United States spends so much is because we pay more for everything. Just about any medical service, any medical good that you can buy, the one thing you can be sure is that in the United States, we are paying among the highest rates, and most of the time we're paying the highest rate. In this chart, this is put together by the New York Times for the from the International Federation of Health Plans, and the United States are the red dots over here. And then for these common inpatient hospital procedures, this is the comparison in terms of what others are paying versus where we are. I have one for outpatient. I didn't show that to you, but I'm going to show you the one here for prescription drugs because this is a similar story. It's also true on the outpatient side, but in the interest of time, because I need to keep going at a relatively quick clip here. But so we pay the most for prescription drugs. Now, of course, these are the list prices here. Most people do not pay the list prices because of the involvement of pharmaceutical benefit managers. But since all of their data is confidential, we have no way of knowing what the real hard number here is, although we have some speculation and some guesses. So those are some pieces of bad news. Sorry to start out your day with some unpleasant news. Maybe here's some better news. This is the national rate in terms of the percent of Americans who don't have health insurance at all, the pure uninsured. Again, going back to 2000, we can see we were in the mid 15% range. In 2010, roughly speaking, just before the passage of the ACA, we were up to 48 million Americans without health insurance, 16% of the total population. The ACA was passed here. It started to take effect in 2010, 11, and 12. And here in 2014 is when the major provisions, the expansions of Medicaid, the creation of the health insurance exchanges, and the subsidized coverage. And we saw here, and we can see it here, a major drop in terms of the rate of uninsurance. And it's been somewhat steady. It went up a little bit in 2018 and 19 in the latter part of the Trump years. And then what we've seen in 21 and 2022 is a significant, again, drop to around 8% uninsured, which is the lowest rate we've seen of uninsurance since we started counting in the early 1960s. Now, importantly, if I were showing those other 10 OECD countries from Western Europe and elsewhere, what you would note among all of them is every other advanced country has a health insurance coverage rate of 99 to 100%. So even though we've gone from about 16 down to 8, cut it literally in about half, we are still a national outlier in terms of our high relative number of folks without health insurance. We can talk more about this if you're interested. Since I know I'm talking to the business community, these are the numbers in terms of people with private health insurance coverage. And again, most of these people are people with employer-based coverage. We have about 25 to 30 million Americans who have health insurance that they purchase individually through carriers. But most of it is people with employer-sponsored coverage. You can see this tends to go up and it tends to go down. It has stayed roughly steady in this range of 59, depending how you count, by the way, 59 to 70% over a significant period of time preceding 2013. And I know this will be of interest in talking about. I want to just demonstrate to you, this is a confusing chart, but I'm going to make it really simple for you. This is the change in the ACA that took effect under the federal ARPA law in 21 and 22, and has now been continued for 3 more years under the IRA, the Inflation Reduction Act. One of the big changes that was done was that in the Affordable Care Act plans, not the Medicaid expansion for low-income people below 138% of the poverty level, but people above that level. 138%, by the way, for a household of 2 is about $25,000 a year in household income. You're below that level, you go into Mass Health or the Medicaid program in most of the states that have accepted the ACA expansion. But above 138%, you go into, if you can't get coverage through your employer, if you're not on Medicare, then you can buy coverage through your health insurance exchange or marketplace. In Massachusetts, we call it the connector, the Massachusetts Health Connector. And you can get subsidies to enable you to make health insurance more affordable. So here is an example. Let's say at 200% of the federal poverty level. You can see this on the left, income as a percent of the federal poverty level. 200% of the federal poverty level for a family of two, it means you're at about $36,620 in household income. Under the original ACA, if you were at 200% of poverty and you bought coverage through the Massachusetts Health Connector or one of the other exchanges in another state, you had to pay 6.5% of your household income as premium to be able to buy coverage. That's a lot better than if you have to pay for all of it out of pocket, which would be much, much higher. But it's still tough for a family living on about 36 grand. So ARPA and now the IRA have changed that. This is under the rescue plan, ARPA, to 2% of household income. If you're at 250%, you used to pay 8.3%. Now you're paying 4%, okay? So this is, and if you're at a lower level, say 150% of the federal poverty level, you had to pay 4%, now it's 0. Also importantly, the ACA limited any coverage for people over 400% of the federal poverty line. And there were, in fact, more than a small number of people who had incomes over 400%, which is about $90,000 for a family of four. If they bought coverage, they had to pay the full weight. Under the rescue plan and now the IRA, their contributions are capped at 8.5% of household income. And it's very few people here, but when they get in that gap, it can be quite difficult for them. So that's important. Here's another way of looking at, now, first it was ARPA, now it's IRA, will continue in 23, 24, 25. By the way, they would like to have made this a permanent change, but then they would have had to finance the costs for 10 years for deficit reduction purposes. And so they were not able to do that in the financial envelope they had to work with when they were creating the IRA. But so this is under ACA, and this gives you a sense of the numbers of people who got helped by the law and then got coverage. And this is under ARPA. The big increase under ARPA and now IRA are people between 400 to 600% of poverty are now able to get much more affordable coverage. Now, there were not a lot of new people who came in under this, but the people who were here, as you saw, have much more affordable coverage, okay? So that's a big deal. That's a big deal in terms of the stability and affordability of the Affordable Care Act that people had been trying to advance for about 10 years, and it happened under ARPA in 2021 and now under IRA. The other big piece in the IRA is, for the first time, the federal government will be engaging in deliberate cost control activities to try to hold down the cost of prescription drugs. Interesting, just a little historical tidbit here. Medicare was created in 1965. It took about 18 years in 1983 for the federal government, through the Medicare program, to start to regulate hospital prices through a law called the Prospective Payment Act that created the DRG, diagnosis-related group system, and all that. So 18 years. Congress created Part D, the Medicare Outpatient Drug Program, in 2003, and it took them 19 years to pass the Inflation Reduction Act that now puts the federal government in the position of trying to regulate prescription drug prices. I've kept this slide up for a while so you can read it and look at it. I'm not going to read all of this because that's not what you do in terms of PowerPoint adequate. And I know you're all pretty sophisticated and smart, but this is an important deal. One thing I would note, which I think is worth the business community hearing, is that when the Democrats released the IRA in late July of this past summer, they were regulating the prices paid by the federal government through Medicare and Medicare enrollees. And they also extended this regulation to provide coverage and cost control in the private commercial market. That was for all of you. And in the Senate debate, because it was what's referred to, forgive the wonkiness, as a budget reconciliation piece of legislation. So it operated under special expedited rules for consideration. It didn't require 60 votes to overcome a filibuster. It required 51. All 50 Democrats plus the vice president voted for it, and it happened. But in this process, the Republicans challenged in this bill the inclusion of private commercial plans. They said that was beyond the scope. By the way, these are the rules that were created by Senator Robert Byrd from West Virginia in the 1970s. We've been living under these now for almost 50 years. And they go to a special session run by the Senate parliamentarian where the opposing party can challenge anything in a bill and declare that it's not appropriate for a reconciliation bill. They call it a bird bath, B-Y-R-D. So this is from the bird bath. And in the bird bath, the Republicans challenged including private business plans, commercial plans in these new regulations. And the parliamentarian ruled that the Republicans were correct and it was struck out from the law. When that happens, they call that a bird dropping, by the way. I'm not making this stuff up. So that happened, but there was an opportunity, by the way, for the business community that buys health insurance or pays for it as a self-insured plan to get protections under this, and it was taken out at the last minute. A little bit on Massachusetts, just take 2 minutes here. So we have had now for 10 years, the Massachusetts Health Policy Commission, which has been in charge of looking at the affordability of all health expenditures in Massachusetts. They established in the 2012 law what's known as the HealthCare benchmark. The HealthCare benchmark, you can see over on the left in the light typeface, 3.6% for the first 5 years, and it went down to 3.1%. Then in later years, it's going to be going back up again next year. And you can see that it's been mixed. We've had years, particularly 14 and 15, when we exceeded the benchmark, but this was during the time of the major ACA expansion. So that was expected and predicted. And then in the succeeding years, we've had a period where we have underperformed. By the way, I'll show you in most of the previous decade, we grew at a faster rate than the rest of the country. And here are the recent years. Of course, this is before COVID. So we were starting to exceed the benchmark in the latter part of the decade. Now we had the anomalous years of 19 and 20 because of COVID. This is the latest data from the HPC that just came out late last month. And just a couple more. This is Massachusetts versus the US going back to 2000. So Massachusetts is orange. The rest of the country is blue. You can see most of the last decade, Massachusetts was growing at a substantially faster rate than the rest of the country. And actually over the past 12 years now, and starting even before the HPC was created, we have been below the national level or just pretty much tied with it. So interesting. This is total health spending. And then one more slide, last slide. This is annual growth of per capita commercial healthcare spending, that's you folks, MA versus US. Here's Massachusetts in the last decade. Here's Massachusetts since the HPC process, and you see a significant change. So making some progress. Is it long-standing? Is it ephemeral? We don't know. But it's significant, it's noteworthy, and importantly, what we can see going on around the country is that there are now about 15 states that have either set up their own version of the Massachusetts Health Policy Commission with a benchmark, with their own bells and whistles and so forth. But we actually in 2012 started a significant trend among states. I think we can see some good results from it. It has certainly kept the intention of everyone on the healthcare cost ball. And so it's noteworthy and important. So I'm sorry I ran over, but I did my best. And I'll turn it back to Peter.
So I just had a motorcycle go by. Sorry, I know we don't want a lot of that white noise, but John, thank you. That was terrific. And you're right. You packed in a lot of information sort of on the national and regional Massachusetts view. And I think it tees up a lot of the elements that we want to kind of get to in our conversation. I first, so let me introduce our panel and get right to that broader discussion. So I'm pleased to introduce the panelists joining John and myself today. And that is, first of all, Matthew Herndon. Matthew is the Senior Vice President and Chief State Programs Officer at Fallon Health. Morning, Matthew. Steve Kerrigan is the President and CEO of the Edward M. Kennedy Community Health Center. Good morning, Steve. And also joining us is Kristen Maddox, PhD, an Associate Dean for Veterans Affairs and a Professor of Population and Quantitative Health Sciences at UMass Chan Medical School. Kristen, good morning. So now that I've done the introductions, and for those who were with us earlier, Brad was on a behind a Mass Pike accident. Brad Kane is the Worcester Business Journal editor, and he just tightened his necktie. So even while I handle the intros, I think Brad can kind of kick off the panel conversation. Brad,
well, thank you, Peter.
Over to you.
Well, the intros are the high pressure part, so that I deliberately just waited until you were finished with that and timed the traffic accident on the Pike to go along with that. But again, thank you, everyone. But John, that was a great discussion, and really looking forward to have you join our panel. So first question, I'm going to start off with a little bit of news, local news-ish, which is the opening of about a year ago of the Veterans Affairs Outpatient Clinic at the UMass Chan campus. Kristen, perhaps putting it a little bit in the context of what John just talked about in terms of health outcomes and how much we're spending and everything else. What has the opening of this new facility meant for healthcare delivery in central Massachusetts?
Yeah, thank you. And thanks to John for that tremendous introduction. I feel like I was right back in graduate school again, learning all of those things over. Yeah, so we opened a new clinic right on the UMass Chan Medical School campus almost exactly a year ago, November, I believe, 7th of 2021. And what that clinic did was consolidate several different sites of care we had in Worcester. For example, we had a very old clinic on Lincoln Street, and we moved the entirety of that clinic to the new space, and also some of the other services we had that had been already at UMass on the 7th floor of the ambulatory care center. So in terms of our abilities to care for veterans, that has certainly greatly expanded as a result of the new building. We very much share a very good and positive relationship with UMass Chan Medical School. We send our veterans right across the sidewalk on several occasions for services we don't provide actually at the VA, some of the specialty care services. And so it has really allowed us to have sort of a more centralized location with a broader range of services for veterans. And, you know, as John said, I mean, you know, this particularly COVID has really hit our veteran population hard, just like everybody else. But, I think especially some of the, kind of isolation that we all experienced during COVID, it's been hard for all of us, and, it's had a hit on mental health for veterans. And so, we're probably just like all healthcare systems right now, just trying to get back to where we were and, to the same level of care that we had. And maybe the other panelists want to comment on this, but one thing that I think has come out of COVID that's been a bright spot is just the ability to provide telehealth services for conditions that, that can be managed by telehealth. And I think that a lot of veterans really appreciate the ability to do telehealth for, certain services when we offer that. So that's kind of our, our new kind of place on the horizon. And I give many tours of our new clinic. And so I'm happy to, provide a tour to anyone who wants to come and see the new space. It's really
great. Thank you. So Steve, over at the Edward Kennedy Health Center, you took over the old space, which was used by the VA in Worcester, and which of course you serve a different population, but certainly very much in need as well. So during the first couple of years of COVID, you were able to implement some changes that, as we talked about in our pre-discussion, were able to better serve your patient population. What worked best during those 2 years? What was really working during the COVID pandemic, and how you changed your delivery? And perhaps how is that being carried forward or not being carried forward? How's it going?
Sure. Well, first, thanks to Worcester Business Journal for this fantastic panel, an opportunity to join with you all this morning. And thanks to Fallon for sponsoring, Brad to you for hosting, and Peter and Kristen for all the great work that you all do. And of course, to hear from Dr. McDonough, who I have followed and admired for a great many years. We both have the resume highlight of working for Edward M. Kennedy, the senator, and now I get to work for Edward M. Kennedy, the health center. So I am glad to be with you all this morning. And thrilled, frankly, for Kristen's new building, because it means we picked up their old building, which was a real huge opportunity for us. And I'll talk about the COVID question, Brad, but I will point out that, my job as president and CEO of a health center is to always try to find ways to increase access to care for our population. 91% of our patients are at or below federal poverty level. 30% of them have no insurance whatsoever. And we provide high quality access to high quality care regardless of people's ability to pay. And so when we find a building that's about 30,000 square feet right down the street from us, it is a huge grab for us, and is going to allow us to significantly expand the services that we provide. Relative to COVID, I think we all in healthcare and in all aspects of life and business changed the way we did things. We have redone a lot of the structure for our administrative offices. A lot of our teams are now fully remote. In the immediate aftermath of COVID, we had been planning for quite a while for its impact. And so we were able, through a massive investment in our IT infrastructure, to move people remote a lot quicker than most. Our behavioral health department was remote in 24 hours. Our billing department was remote in about 2 days, which was a critical piece to make sure that we could continue to do those services. And really, for us, it was investing in our core mission, in our patients and our people and our places, and making sure that our health centers stayed open. We never laid anybody off. We never closed a line of business. We kept our health centers open throughout. I will echo the focus and support on telehealth. It made a huge difference to our ability to deliver services, although we're glad to get people back in the clinics now. But having that opportunity and option, particularly for our patient population, where they don't have to take a day off of work to come and get healthcare, they don't have to worry about childcare, to come and see their doctor for a quick routine checkup. It's critical to our ability to provide the care, but their ability to be an active member of our economy and in our community. So it's a big piece of the work we did. But really, for us, again, it was staying focused on our mission. It is allowing us to expand our services at the new building. We're moving our dental department, our optometry department, all of our behavioral health, and we're opening a true urgent care in the community at that site sometime in 2023. And freeing up the space at our main clinic will give us access to, a dozen more exam rooms for primary care enhancement and other specialty care. So it's a real big opportunity for us. And so again, we're thrilled that the VA moved. I look forward to getting a tour of your site, and look forward to welcoming you to see the see the site once we're done with the renovations.
Well, great. Thank you, Steve. Matt, we haven't heard from you yet, so I'm going to ask you the hardest question of everyone, just to be absolutely fair. First, Matt, and then anyone else who wants to chime in, feel free. But what are you seeing on the state and federal level in terms of the priorities being set and how that's actually working out on the ground? I know John talked about a lot of things that just happened, and I can't imagine that's necessarily impacting delivery yet, but maybe, and I guess maybe how you see it impacting delivery.
Yeah. Brad, thank you. I just want to echo Steve's thanks to the Worcester Business Journal for having us all here today. Thanks to Dr. McDonough for the keynote remarks. And it's great to be here. I think that obviously COVID continues to impact the healthcare landscape in really significant ways. As Steve mentioned, there was a lot of innovation that occurred during COVID and that continues now. And I think one of the big questions is how much of that innovation is really here to stay on a lot of fronts, whether it's telehealth or other initiatives that I think have really made a difference for patients, including patients in the greater Worcester area. I would say at the highest level, what we've seen in efforts like the Inflation Reduction Act is a real desire to kind of make more permanent the support that a lot of patients came to rely on during COVID and more so. And so, for example, we have a public health emergency that was declared during COVID. That's actually been extended until mid-January, and that has a lot of impact for people in day-to-day lives. It has meant extended coverage, for example, in individuals who are enrolled in the Medicaid program here in Massachusetts and across the country. So there are developments like that I think we're really looking to see whether they become more permanent. I think the other thing that came out of COVID was really a recognition, a greater awareness of a number of gaps in our system. And so switching to the state level, I think there's been really strong recognition that we have some work to do in a number of fronts, and there have been really important investments made. So, for example, the Baker administration issued its behavioral health roadmap. And within that roadmap, there was a focus on a number of areas, including really better coordination of behavioral health care, fundamental capacity building. And so some of those sorts of policy goals have now manifested themselves in areas like the state budget, where the funding for an access line has been granted. There have been some updates through a BH law, also known as Chapter 177, that really is building capacity in the BH space. There's been, I think, a greater awareness, and really more than awareness, a move to action in the area of health equity. And I'd love to talk about that a little bit more, including this panel. And then I think just a fundamental reappreciation of the role of primary care in the healthcare system. And I think, Steve and Kristen can obviously speak closely to that. So those are just some very kind of broad brushes that I would say have come out of COVID in a really positive way. And I think the question is, how much of this can really stick in a permanent way moving forward?
Well, great. Thank you, Matt. And before I move forward with the panelists, I would just encourage all our audience members, if you have any questions, type them right into the Q&A there, and we'll do our best to get to everything, because we talked about a lot of things in advance, and we have sort of our agenda, but we want to hear from you as well. Matt, maybe, and I'm going to open it up to everyone, following up maybe a little bit more in depth about something you mentioned, which was health equity, because looking at a lot of the scary/disappointing numbers that John put out in his presentation, I think a lot of that impacts our most vulnerable populations, who have been historically marginalized, are the ones being hurt the most kind of by the negative trends in the market right now. Matt, I guess I'll just open up to talk a little bit more about health equity and how do we get.
Yeah, and let me just touch on a couple of points and obviously look forward to the broader conversation. But again, I think COVID really revealed for many the incredible disparities that were occurring across different communities, underrepresented communities. I think there's a greater awareness, for example, in areas like maternal mortality rates among Black women or Native American individuals. I mean, these are the sorts of areas that have really risen in terms of, I would say, general awareness. But I think what's different is that we're at a point, and I would say this is particularly the case in Massachusetts, where we're really moving from awareness to action. And that action is really manifesting itself through the formalization of requirements. For example, as a health plan, accreditation through an organization known as NCQA is very important to us. They are they have established a health equity accreditation standard that we are working to meet, which has all sorts of requirements. But that's an example of how we're really moving from what I would say is a moment of awareness around the issue of health equity to actual action. So that's just one point I would make about the broader topic.
John, Kristen, Steve, anyone want to jump in on health equity? John?
Yeah, I'll weigh in. Way back when I was in my graduate programs in the 1990s, we learned that there were basically three pillars to healthcare policy in the United States. There's cost, quality, and access. And everything fit under one of those umbrellas. And after the ACA passed, I thought that we'd added a fourth called population health. And that we'd reached a new place where it wasn't just enough patient by patient. We had to look, and we had the mechanisms with the value-based care revolution in the ACA to actually do it and make it real. After the past 2 years, I've actually thought there's now a fifth, and the fifth is health equity. And I think, in the past, before 2 years ago, I would have said, well, health equity is embedded in access. It's embedded in cost. It's embedded in quality. It's part of all of those things. But I think one thing that has happened in terms of a consciousness raising, a revolution of awareness in the past 3 years or so now is that that's not good enough, and that it has to stand out and stand on its own and be looked at as a separate urgent priority. And I see that all over the healthcare system. I mean, our major leading journals, JAMA, Health Affairs, New England Journal of Medicine, never or rarely ever had the word racism in those journals. And that's a fundamental change. I teach exec ed. I taught a program a few months ago with about 60 leaders of academic health centers across the country. And I said, raise your hand if your institution is doing something new in the past 2 years on health equity. And every hand in the room went up. Whether it's real or for show, it's a different moment. But then the other piece I'll just add is that there's this now, we've seen over the past 18 months or so, a significant backlash to this with attacks around critical race theory. And so now it's become a really electrified arena where there are sides. I asked a friend of mine who's a leading Republican staffer from years ago, who are the voices on the conservative Republican side who are articulating concerns, thoughts, and agenda around health equity? And her conclusion was there's nobody doing it because if you do that, you get into saying, oh, you're embracing critical race theory. And it's kind of a form of Trumpism. And so I see this unfortunate fissure within society around this. As I look at what I think is some amazing advances forward in terms of recognizing this as an arena that we all have to pay attention to in a much more substantial way than we ever had before.
Yeah, and
sorry, go ahead, Kristen.
Yeah, I can chip in on there too. So on my sort of other day job, I'm a women's health researcher in the VA, and I really focus a lot on maternal health. And so we did a study a couple of years ago that found like crazy disparate rates of C-sections among Black women, particularly at our Southern VA facilities. I mean, to the extreme of like in the same area, basically 70% of Black women would be getting C-sections, and basically 30-ish% of white women would be getting C-sections. And, this is after controlling for all other, factors, comorbidities and things like that. So, we've been going down this path the last 2 years of figuring out like, how do we, turn that around? And so we're doing two things right now, and it's definitely going to take some time, but one of the things is we just got a new grant to support doula care for women veterans of color. The literature definitely shows that when women have supportive sort of birth experiences, they're less likely to have, sometimes C-sections and poor outcomes and things like that. But to go on something Matt said, the other thing we're trying to do is really educate women about sort of quality metrics at hospitals. And so, the hospital you're going to deliver at, what is their C-section rate? What is their, rates of sort of bad things happening to newborns, and trying to get women to the place that, they know that they can make a decision about which hospital, they choose to deliver at. And so I agree with John, it is such a hard nut to crack, and just even in the smallest ways, working on things to do that. But, I just spoke to a woman yesterday from North Carolina who's going to be doing our doula study. And she literally was crying on the phone when I was enrolling her in this study, because she said her last birth experience was so bad. Nobody listened to what her preferences were during labor and delivery. People sort of roughly handled her. And she just was so overcome with emotion at the ability to have somebody support her during the labor and delivery process. And so I'm all in, John. I'm working with you on on health equity, and it's a lifelong career basically to address those issues, I think.
And so for us, first of all, I agree with the renewed focus on health equity for community health centers. This is not a surprise or a new thing. It's what we've been doing since 1965. The entire community health centers were born in Freedom Summer by medical volunteers, Dr. Count Gibson and Jack Geiger, who followed the Freedom Riders to the South on the buses with them to patch them up when they got beat up, and where they witnessed firsthand the inequities of our healthcare delivery system. And they went back up north, founded the health center on Columbia Point in Dorchester, where our former boss went in 1966, saw it, and went to Washington to fight for community health centers. We've been doing population health and social determinants of health-based work for more than 50 years here at the Kennedy Community Health Center. And health equity has been a huge part of the delivery that we do, and a huge part of the value that community health centers bring. I will say, very few people in American society realized the value we brought until March of 2020, when the 29 million Americans that we take care of at community health centers, and the 1 in 7 Bay Staters that we take care of, didn't lose their care, continue to get high quality access to care, and had that support that they needed. And furthermore, those folks weren't ending up in emergency rooms to get critical care. We gave away 25,000 vaccines in that first year. We've continued to give that critical primary care so that at-risk population has that access. So I'm totally on board as well, John, on the push for health equity, because we've been doing it at community health centers for more than 50 years. We're just thrilled that the healthcare delivery system overall is finally realizing the importance of it and the value of it to the patient population, and to your presentation, to the overall cost of healthcare. I agree with what Matt said earlier about primary care being such a critical tool to all of this. And if we're investing more in primary care, which, by the way, I will give credit where credit is due to the Baker administration. They have done great investments in the work that we've done at community health centers. And the Biden administration has given the largest investment in community health centers since probably the George W. Bush administration, when they doubled the number of health centers. But the work needs to get done at the levels that Kristen's talking about in terms of maternal morbidity and other work. We deal a lot with patients with asthma, with diabetes, with chronic illnesses that can be dealt with if you're dealing with the root causes and giving them the support that they need, which I will say, and I know we're going to talk about this probably a little bit later, but in case we run out of time, one of the ways we can help both with health equity and some costs is if we put things like interpretive services, community health workers, health benefit coordinators, all of those things into the total cost of care. We spend $1 million out of pocket at Kennedy Community Health just for interpretive services to help our patients who speak 92 different languages get care in their own language or to be able to understand the care that they're getting from their doctor. That is a cost of care. By not paying for that or allowing people to bill for that, you're taking away that patient's ability to get quality care in a way that they understand in a culturally competent way. So that, I think, is what's next when it comes to costs, is putting things like that into the billing system and into the cost components, because it's not just about the vital signs and the assessment from a physician. It's all the work that goes into creating that moment for that patient.
Can I add one thing, Steve? Steve, you kind of triggered a thought, something I wanted to say, but I think it's a good place.
I
to
trigger
say
a
it.
lot of people in a lot of ways, John, so I hope it's in a good way.
So, you know, I've been around for a while. I'm 69 now, so, and I've seen a lot of economic downturns over my life, as everybody has. And in every single economic downturn in my lifetime, when the economy goes down and people lose jobs, the people without health insurance, the numbers spike upwards. And the first time since the ACA was signed in 2010, the first real economic downturn that we had since the signing of the ACA was in 2020 with the COVID economic crisis. And in that downturn, because of the structure created around the ACA, we saw no spike in the numbers of people without health insurance. We had stability because even if you lost your job, maybe you could go into your Medicaid program, maybe you could go to the exchange and buy affordable coverage there. And it's just, it's not appreciated, it's not recognized, but it's a stunning win in terms of what we hoped would happen, that we could flow through downturns and not have people's health lives get completely messed up.
Well, it's great. I mean, Brad, I don't want to take over the conversation, but 29, just a data point, 29 million Americans had a job loss related healthcare interruption, but they immediately were able to pivot because of the ACA onto other options. And you're absolutely right. It was a game changer because people could continue to get care and didn't hide and let critical issues build up inside them.
Kristen, I'd like to jump back on maybe kind of a relatively minor point that you made, and I think our largely a medical audience will have to forgive my ignorance a little bit, because I think maybe this will speak to, like, on health equity, why outcomes are so different. But just talking about women who receive C-sections, and you mentioned, 70% of I think Black women end up getting C-sections, about 30% of white women. Why would a woman need a C-section versus, a vaginal delivery, and like, how can better care change that?
Right. Good. Super good questions. So I'm actually the proud recipient of 2 C-sections myself. Sometimes they're just needed. I mean, my first daughter was breached and there was no time to turn that around. And, and then the second one, there's this sort of practice called vaginal birth after C-section, where it really is encouraged that you at least try to have a vaginal birth after C-section, just because there's less, bad outcomes, but those can fail. And so you can have another C-section. So there's very good medical reasons either for the woman or for the baby to have a C-section, that it does happen. But there's sort of less good reasons to have C-sections. So what we're finding with the Black women that we talk with in sort of our Southern VA sites is that oftentimes C-sections sometimes happen because a doctor is off duty on Saturday and wants to have the medical procedure on Friday to get it wrapped up, so he won't be around Saturday. That can happen. C-sections are definitely also more profitable for the healthcare system. It's sort of more time in the hospital, more sort of expenses. People some women that we've talked to who go into, the doctor, especially after already having a C-section, aren't given the opportunity to try a VBAC. And so that's sort of also a bad thing that can happen. So there's very good medical reasons why women have C-sections, but there's also really bad reasons as to why they have C-sections. And so what we're trying to do is, drive it to the place that that women have C-sections for very medically appropriate reasons, either for themselves or for their infant, and get away from some of these reasons in terms of convenience for the physician, or, there's definitely also some kind of, what we're finding with Black and Hispanic women is just, sort of lack of trust and respect towards these women from healthcare systems who don't take the time to listen to what their preferences are for births and things like that. So you and I could sit down and have many cocktails and talk about this, but it's definitely a problem, and it is a huge racial difference that we see. Particularly in some areas of the country. It's a much worse sort of problem in the South than it is up here in the Northeast. So hope that answered your question.
Yes, I was a little afraid of the answer, and I'm
sorry, I got kind of grizzly there for a little bit, but
it does kind of, I think, a little bit to what Steve was talking about too, is, with it, like interpretive services and delivering services to people in a way they understand, in a way that's culturally appropriate.
oh yeah, and I'm glad that you mentioned that, Steve, because as I was driving through Worcester the other day, I was thinking about what you said, and I was telling my daughter about the fact that you serve people in sort of 91 different languages, and we spent some time driving trying to think of 91 different languages.
Yeah, I can't possibly.
We couldn't come anywhere close. I think we got to like 10 or 15. So really impressive. But if you speak with someone like Tiffany Moore-Simas, who's the chair of OB-GYN at UMass Chan, she says the same thing that you say, that women, Worcester is such a wonderfully diverse place, and you come to UMass and you deliver your baby, but you don't speak so they have the same issue as you. You have to have 91 different sorts of interpreters come and be with the woman in the labor and delivery room to facilitate that process. It's such a challenge in Worcester, I think, with just the huge amount of diversity there.
It really is. Yeah. And it's, we're lucky. 76% of our staff speaks 2 languages, are bilingual, and 23% of those folks are trilingual or more. So, before we even get our interpreter in a room, there's usually a chance that we can have some sort of conversation, but we do so much on telephonic interpretation. And then we have a thing, it's basically an iPad on a rolling stick that you can hit and ask for a specific language, and then an interpreter will pop up their face and they'll be the person communicating. I've seen it firsthand many times, particularly with our Afghan refugee families who are coming for health assessments. I will say the kids and the families loved looking at the iPad and talking to the interpreter, which is fantastic. But it immediately, you see their anxiety level goes down because they have somebody who can communicate with them in a language that they understand, and sort of makes an otherwise really probably awkward and confusing experience a lot more settling for them.
Brad, I wonder if, I wanted to pick up on a point that Steve made around social determinants, and also something that I forgot to mention in the context of kind of federal developments. But the one area that I wanted to just touch on was the area of just food insecurity. I think we all have very lasting images of the drive-through food delivery lines, food donation lines during COVID. And I think each of us can probably attest through our respective positions that food insecurity remains a pretty significant determinant of health, including in the greater Worcester area. I know that it's a priority of Fallon's, for example, of any of the attendees here today have been lucky, to go to a ball game at Polar Park. We had the Strike Out Hunger campaign. It's an area of focus, but more seriously, it's an area of really a need for continued work societally and within this region. So I did want to kind of throw that out there. There is, good news to kind of build on John's themes. For example, in the Medicaid program, where we're very active, there's a real focus now within this program through something known as a flexible service program on food insecurity, along with homelessness, which is a whole nother topic that we, would be great to get to with more time. But I'd love to kind of just throw out the food insecurity issue. It's so significant, it's so pronounced, and it's an area of real commitment, I know, on the part of Fallon, and I know other organizations here.
Yeah, so I thank you so much, Matt, for bringing that up, because that is that, and then I will shout out Worcester just received word that HUD is investing a significant amount of money here from a housing insecurity perspective. They just announced it on Monday to try to get particularly youth who are suffering from housing insecurity stabilized. But food insecurity is a big thing that we see in our health center. We actually partner with REC and Eat Well, which is a great program, and Project Bread. This past Friday, we actually did a food distribution at Worcester Housing Authority at the Great Brook Valley housing complex, where we were founded, right in front of the building we were founded in. And it's amazing to see the folks who are, getting their kids off the school bus and then getting right in line to get some basic foods. But it's a critical part. That, and then the flip side of it is the nutrition services, which we are thrilled to offer. And I know Chris and you do as well. Nutrition services and working with patients to make sure they have the resources and understanding of how they can eat better and live healthier lives. Our motto is we help people live healthier lives, and it's not just through medical care, but it's through those SDOH as well.
I think it's worth noting, particularly with the with Governor Baker riding off into the sunset with his team, that over the past 8 years, mass health has been reinvented in the Baker administration, particularly under the leadership of the dynamic Health and Human Service Secretary, Mary Lou Sutters, who is a force of nature unto herself. But they have reinvented that program with the support of the federal government, the Centers for Medicare and Medicaid Services, to create 17 mass health accountable care organizations that no longer deal with patients on a fee-for-service just when they show up at your door, but actually have responsibility for the total care management of those individuals and their families. And it's now, I believe, over 1 million Massachusetts residents are in one of those 17 ACOs. One of them, by the way, a national model, is an ACO only of community health centers. And I'm wondering if I can, Brad, if I could be presumptuous to ask Steve a question. I'm wondering your view of how big a deal has that change been in terms of how healthcare is delivered in Massachusetts, and what do you think we're learning from it?
So I think it's a bit of a double-edged sword. It's been fantastic. We happen to be in that ACO. That is C3, which is all community health centers. It's about, I think, 19 of us now. It's a fantastic model for us because we have that collaborative service with each other. But the downside is there are these metrics that, yes, a bunch of our patients are C3 patients, not all of our patients. So we're tracking the metrics for some and not 100% for others. So it creates a little bit of a disparity there, which we try to measure out. And then the other aspect of it is the resources. We're given quality measures and things to accomplish on a given year. And we then have to hire new people to do it, to accomplish it, whether it's population health people or nurses or MAs. And more often than not, no funding comes from that. And so it creates that push and pull where we want to do it. We need to do it, is the right thing to do. But we want to have that balance too. But on balance, it's been a huge success, and I think has led to a big improvement in. Well, I know it's led to a big improvement in terms of the services and the quality of care that we've gotten, and the tracking of some of the critical illnesses that our patients live with each and every day. So it's been a huge success. I just would say, as with everything, as you highlighted at the beginning, the cost of care is a significant thing, and to those who aren't as mission driven as those of us in the community health center world are, it is a dollars and cents issue when it comes to setting these metrics without any financial support to meet them. We're glad and honored to do that level of care, because we're in a financial position at Kennedy Community Health where we can do it for them and for our other patients. But it does set up that sort of split between ACO patients and non-ACO patients. But all in all, it's been a fantastic model.
Yeah, and I would echo Steve's comments. I mean, Fallon is a participant in the ACO program as well. You have health plans that can also partner with providers. And I think that's what is so unique and innovative about the program is you really are bringing providers and payers together in one of these ACO models. And you're really trying to build on the respective strengths of both organizations, whether it's like the care management capabilities of a Fallon Health, or the clinical expertise of an organization like Steve's or other provider practices, or even hospitals in some cases. But there are really strong measures around accountability. But that's a good thing, right? Like whether it's health equity or whether it's primary care-based practice and integration of behavioral health into those primary care practices, that's a good thing. And so we kind of like willingly take up that challenge. It's complex, but it's also like this great opportunity for innovation. And I think what's been particularly positive about this ACO program is the Baker administration is also really, kind of funding it in a way that is incentivizing these efforts. So for example, on the new ACO program, there's an incentive payment around health equity efforts. There's an incentive payment around really integrating BH at the primary care level. Like those are good things. And it's really the administration kind of backing up these policy goals with important incentives to try to move the healthcare landscape, particularly, in this Medicaid realm, to really what is described as value-based care at the end of the day. But that is very patient centered, very team-based, very integrated.
So getting a couple of questions in from the audience, jumping back to food security. Jody Bridell, I'm sorry if I mispronounced your last name, from the Wheat Community Connections, which is part of the United Way Services of Tri-County. How do we keep rewarding social service agencies who work closely with residents to promote access to healthy food, housing, et cetera, so they don't end up at the hospital? I'm just going to throw that out to whoever wants to answer it first. Or I'm going to pick on somebody.
I mean, I'll take a crack at it. I mean, it's a resource issue, certainly, in terms of how we reward the social service folks who are providing the care. But it's got to be, I think, cross community. And I think I will say I'll give great credit to Tim Garvin and everybody at Worcester together who sort of brought all the social service organizations and partners together during COVID and still work together hand in glove on tackling big issues. But food insecurity is a huge issue. We deal with it with our patients all the time. I think it has to be a holistic approach from providing people opportunities to access fresh food, but teaching them how to cook, teaching them where they can access it. It can't just be about food pantries. That has to be a piece of it, but it has to be about nutrition training. It has to be about that access in their community and not just 20 minutes away where they have to drive to pick up food at a food bank. It's similar to housing, where you can't fix the housing problem by creating more homeless shelters. You've got to create more home ownership opportunities and more rental vouchers and more access to low-cost mortgage rates, things like that. I mean, there's a whole accordion of opportunities that exist for almost all social determinants of health. And I think food insecurity is a big one. But it's like anything, Jody, it's about prioritization. And so it's whether the federal, state, or local governments prioritize tackling food insecurity. I think we are luckier than most on any given day on any given topic to have Jim McGovern as our congressman here in Worcester. But there's no one who has fought harder since probably George McGovern on food insecurity in the United States of America than Jim McGovern, and just got the first ever White House conference on hunger and nutrition and food insecurity done a few weeks back. Deserves a great credit and is working tirelessly to try to tackle that issue, but there's no easy answer, but it is a matter of prioritizing it in the federal budget and prioritizing it in what we do as a community.
Well, great.
Yeah,
Thank you.
I would just add, Brad, that the social service organizations are a vital part of the overall kind of healthcare infrastructure. And while we may not think of them in the same way that we think of our PCPs or providers, they are a really important part of the larger healthcare landscape. I'm going to go back to Medicaid again, but there's another example where we have a program known as the Community Partner Program, where we are required as ACOs to work with these social service organizations around these social determinants of health issues like housing and food insecurity. So there is a really kind of vital role for these organizations in addressing whether it's social determinants of health or broader needs of everyday people. So, really, really vital part.
All right, with just under 15 minutes to go here, I maybe want to jump out to something a little higher elevation. And John, I'm going to direct this first to you. You had maybe looking at that ultimate of healthcare metrics, which is life expectancy. And you had the very stark chart showing that about 40 years ago, we really started to diverge from peer nations in our life expectancy here in the United States. And it's really only gotten worse. But I'm hoping you're about to give me some good news because, we have ARPA, we have the ACA, which is 10 years old at this point. We have the Inflation Reduction Act, the poorly named Inflation Reduction Act. How do you expect all these changes that are happening now to maybe impact life expectancy? And, I'm going to ask you to actually put a number on it. Are we ever going to get back to where we've narrowed the gap entirely with the peer nations? Is it going to happen in, 2 years, 2.5 years, 1 year?
So I'm gonna beg for some assist from Kristen Maddox here as a professor of population health, because I think that she's much more in this wheelhouse than I am. I don't think that the kinds of changes that we see in ARPA and the Inflation Reduction Act, with people being able to get coverage and hold it, it's valuable, it's important, it's life-saving and preserving, but I don't see it as being large enough to really move the needle. And the larger forces at society are the growing amount of overweight and obesity in American society. I mean, that's just an extraordinary challenge. And by the way, there's two categories. There's overweight and there's obesity. And if you look over 40 years, the rate of overweight in American society has actually been pretty stable. What has grown enormously is obesity, and including morbid obesity. And that's a crisis among so many other population health factors that we're facing that I think kind of dwarf the impact of things like the IRA and ARPA. But I'd invite Kristen to jump in and say whether she sees it the same way.
Yeah, and the place that my thoughts first went is just like the incredible sort of impact of COVID and how it hit different racial and ethnic groups very differently. And so the life expectancy, I can't remember what the numbers were, but it had a much, much larger effect on minority Americans, Blacks and African Americans, I think, than any other racial ethnic group. And that and in the VA, I'm probably with your healthcare systems too, we spend a lot of money right now looking at long COVID and, this long-term impact that people are having with COVID. I don't know that we've necessarily seen differences in, obviously life expectancy at that point yet, but I think that's something that's going to be with us for a long time. And we have no sense of who gets long COVID, who doesn't get long COVID, and what the long-term outcomes are. So, my thought about that is part of it really depends on how much COVID continues to impact people over time, who were really hit hard with COVID. and God knows what's going to happen in the coming months, right? With new waves coming again and again, we can't catch a break. So it's a hard question to answer, but I think I keep coming around to the important racial and ethnic differences and things like that. And again, trying to figure out, like, how do we really, help those people whose life expectancies have been really, really impacted by, like you said, overweight, obesity, but also big things like COVID as well.
I would just add to that, though, I totally agree on the racial and ethnic differences, but hearkening back to Deaton and Case's book on deaths of despair, and their focus was looking at low-income whites in the parts of the country that have been most affected by the opioid crisis, Ohio, Kentucky, West Virginia, and the stunning demarcation between people who have completed high school or particularly college, and people who haven't completed high school, and the stunning health data around that just is arresting and mind-blowing.
Yeah, I agree completely. And I think in the past year we watched that, the making of the book into a movie, The Dope Sick. I don't know if you saw that. It was on something HBO, and my goodness, I think watching that series changed my life more than anything had in a while. It was absolutely stunning. And kind of back to your point, John, the really targeted the targeted nature of how that drug was first rolled out in these very poor mining communities of West Virginia and Pennsylvania and Ohio and places like that. And then it's funny because we aren't talking as much about the opioid epidemic as we used to, but it's still there and it's still big. And just the amount, I saw something the other day about the opioid deaths, and they're still huge. It's massive. So that is a really good point that you made. I appreciate you making that point.
I will say we not to get too far on the substance use disorder track, but it's a huge part of our practice at almost all of our sites, and growing, sadly. But we've got a lot of patients involved in our MAT program. We've got a great team who's working to tackle that. But you're right, Kristen, COVID sort of hit a lot of what was still going on, which was significant substance use concerns and issues. And we see it each and every day at the health center. And I will point this out as a PSA. You do not have to be a patient at Kennedy Community Health to walk in the door and avail yourselves of our substance use disorder and MIT program. So if you know anybody who is suffering with substance use disorder and they need care, send them to 19 Tacoma Street, and we'll get to work, help them out.
Matt, I think the original question, and I really like the direction that you all took it, was about just life expectancy and maybe ways that it improves or does not. From where you sit, maybe how can things get better, or will things get better, or?
No, I mean, it's a great question. I think you've heard kind of good themes of optimism during the course of this conversation. One of the things that a health plan has and brings to the equation is data. And so, we have such an opportunity to leverage and build on the data that we have in the healthcare system to really make important changes, whether it's new innovations, whether it's zeroing in on health disparities based on any number of factors. So I do have optimism about our ability to really continue to make improvements, notwithstanding the sorts of trends that John highlighted. And I think in particular in Greater Worcester County and Massachusetts, what is particularly grounds for optimism from my perspective is there really is kind of a very much a common view that we have to work on this together. And you saw that with early healthcare reform efforts that John was very involved in. You see that in kind of the near universal coverage rates of residents of the Commonwealth. You see it in commitments and now funding in the behavioral health space, in the health equity space, catching up with kind of work that Steve's organization has been doing, as he said, for decades. So, we're moving in the right direction, but this is hard day-to-day work. But I think it's the commitment that the Commonwealth and the various stakeholders have kind of demonstrated over time that gives me really the most optimism.
So 4 minutes to go. So not a whole lot of time left to explore any other big issues, although we've certainly covered a lot of ground in the last 90 minutes. But I think I'll just open it to each one of you. Again, keep in mind that we are on a bit of a clock and we want to be respectful of people's time. What one message would you like to leave with our attendees and just the Central Mass audience in general before we sign off? And Kristen, why don't you go first as I put you on the spot?
Yeah, I would just say, I am big and believe in the power of, partnerships across our sort of healthcare organizations and entities. And, even though the VA is kind of a funny insular system, we really do depend on our relationships with UMass. And, I know that we've worked with Fallon. We're starting to do some work with Fallon on some areas. And, Steve, I'd love to figure out a way to, work with you guys. So to me, that's what's critical, because I don't think any one of us can do these things together. And we really do need to rely on sort of each other to care for these populations. So I think that's my closing message.
John, why don't you let us off? How about you? Any parting thoughts?
I think I'm struck by listening to the reports on the ground from the Worcester area, something that I see reflected everywhere, which is tremendous amount of dedication, commitment, good work, caring, smarts, that is so valuable and important, especially in a system which is just at this point a little bit unable to deliver what society really needs. And I think that's because the problems of the healthcare system go beyond the healthcare system itself. It's not Matt or Steve or Kristen's fault that we have an obesity epidemic. It's not the fault of the medical care community of the opioid epidemic. It's not the fault of with gun violence and all of the other big important afflictions particularly in terms of inequality and income inequality. But we have to continue moving forward to try to address these, because we are in the healthcare system on the sharp end of so many of these dysfunctions and these important urgent social needs. So I'm just heartened to hear about the good work going on in Worcester. Congratulations to all of you. And I think it reflects good things going on, but still some awful mighty challenges ahead.
All right, Matt, maybe we're kind of running out of time, but certainly want to hear from both of you.
Really quickly, I would just say we all have a stake and a role in having the healthcare system that we want in this state, whether that's your role as an employer providing, employer-based healthcare coverage, whether that's volunteering for a social service organization or a cause in the healthcare space. We all have a role to play and a stake in the healthcare system that we have in the state.
Steve, parting thoughts.
They are brief. They are just thanks to you all for hosting. Thanks to you all for your commitment to creating a healthier community for frankly, for all of us. We are excited to be a part of this partnership. As Kristen pointed out, it is all about partnerships in our community. And I would encourage anybody. We are opening a new building in Worcester. We're opening a new building in Milford. Anybody who wants to come by and see the great work done at Kennedy Community Health, It is all about increasing that access to care. We're proud this in the past year to have launched a trans health program that has doubled our patient population in the last few months. So we are constantly working to find new avenues to increase access to care. So if anybody has ideas or wants to support the great work that we do at Kennedy Community Health, come on down. Thank you again.
All right, well, great, and thank you, everyone, for the really insightful conversation. You know, it's wonderful when you get a bunch of people with really big brains and a lot of expertise in a room and get them talking about issues they're passionate about. And I just really, it's a very insightful conversation for me, and I imagine it was for our attendees as well. Dr. John McDonough, thank you for your keynote, and again, our esteemed panelists, Matthew, Christian, and Steve. Once again, a special thanks to our presenting sponsor for this annual event, Fallon Health. And lastly, a reminder to everyone that we will send a link to a recording from today's session in a post-event follow-up email. It's 10:01. Everyone have a great Tuesday, and we'll see you again soon.
Thanks, everybody.